Thank you very much. I really appreciate Dr. Osman for giving me this opportunity, and thank you for the Egyptian Society of Nuclear Medicine for letting us to join you. And thank you very much. Hopefully, we will meet your expectations on this presentation. So I will mainly discuss the paper. So this is hopefully, can you see my full screen?
Yes.
Okay, perfect. So this is the outline of my presentation. So I will be having few words about the introduction of Alzheimer's disease. Then I will be discussing like in the main points. Yeah. Then I'll be the main points of the paper as outlined. Like I will be discussing the background, rationale, and the goals of the updated appropriate use criteria, and the development and methodology they use to produce this paper. And I will be having few words about amyloid and tau PET, integration of this molecular imaging with biomarkers. And we will be discussing the clinical interpretation and reporting of these amyloid PETs. And I will be having some clinical case examples as well from here. Then my presentation will be concluded discussing about the further research questions, which was discussed in the paper regarding amyloid and tau PET. So, okay, to start with, Alzheimer's disease is it's a progressive neurodegenerative disorder that primarily affects memory, thinking, and behavior. You can imagine how it will be devastating to be forgotten by someone who is your father or mother or your loved ones. So it's a kind of progressive disease. Sometimes they call it proteinopathy. So and in terms of its epidemiology, this is a US data. It's expected to affect about 13 millions by 2060. And currently, as per the 2024 data, there are currently about 6.9 million people living with Alzheimer's disease, which is above the age of 65. In terms of the treatment, there is no cure currently, but there are disease-modifying treatment agents that I will discuss them in the middle of my presentation, which is actually one of the reasons for this development of the appropriate use criteria. So I was trying to look at local data in Egypt, how the prevalence of Alzheimer's disease or dementia is. Um, well, there is no specific single official number that I get in the website, but I think this paper, which was done in the Upper Egypt area, they came up with this prevalence. They said it accounts about 1% of the population aged above 50 years, and it can reach up to 10% of patients above the age of 80 years, which is a very, very huge number. So this paper was published in the Egyptian Journal of Neurology and Psychiatry and Neurosurgery. I was trying to see how they collect the data and how they came out with these numbers. What they did is they did a door-to-door survey. There are a group of 7 neuro psychiatrists. So I think they include in their research about 12,000 patients, not patients, like individuals with a screening questionnaire. And they were, when the individual is positive for neurocognitive abnormality, they invite them for further assessment to the Aswat University Hospital. So this is the available data that I got regarding the local figures. I will be more than happy if there is anything that I miss, you can share me. And like you can stop me anytime in the middle if you have any question or any suggestions. Okay. Having said this about the epidemiology, then I think it's very important to understand the pathophysiology or so Alzheimer's disease, as I said, is a neurodegenerative disorder. There are key proteins in the pathophysiology, which is called the amyloid cascade. So we have the amyloid beta and the tau protein. So there are the key proteins which plays a big role in the pathophysiology of Alzheimer's disease. So under normal circumstance, this is a very nice figure I'm going to explain to you now. So under normal circumstance, the amyloid and the tau proteins are they're important components of the neurons. For example, the tau protein is it's important components of the cell body for the cell body I mean the for the axonal integrity. And amyloid is important component of the synapse. But for some reason, if there is misfolding of these proteins, they can aggregate in the nervous system. And this aggregation of proteins are toxic. So, and the key difference between these two main proteins are amyloid is outside of the neuron, like it's outside of the cell, it's extracellular, and the neurofibrillary tangle or tau protein is inside the nerve cells. It could be part of the reason that having a positive amyloid PET scan doesn't necessarily mean you have the neurodegenerative disease or Alzheimer's disease. Yeah, part of the reason we can see it in normal people as well, but there's no strong correlation between the amyloid deposit and the clinical manifestation of Alzheimer's disease when it comes with amyloid. It's just part of the extracellular. But um, tau protein has a tendency of strong association with any sort of clinical manifestation of Alzheimer's disease. So having said this, now let's dive into the yeah. So I would like to highlight or discuss about the available ready tracers as well. So currently in the market, we have three amyloid tracers and one tau tracer, that is fluorotaucipir. This one, the tau tracer was approved by the FDA in 2020, and I think the amyloid tracer has been there since 2014. These are the three common ready tracers that we use for imaging. They are all similar. At St. Louis University Hospital, we use the Amyvid or F18 fluorotaucipir. So these are currently in the market. These are the amyloid and tau tracers available. Okay, so now I'm going to dive into the paper. This is a paper that we're going to discuss. It was released this year. So then to start with, what is the background and rationale for this paper? So the 2025 update revises the existing 2013 amyloid PET appropriate use criteria. This new appropriate use criteria comes with the appropriate use criteria for tau PET, which was not there in the 2013. And this reflects, this new appropriate use criteria reflects the FDA tracer approvals and the new anti-amyloid therapies. Said I will be discussing them like in the middle of the presentation. So and the other thing is the CMS coverage for the reimbursement purpose. There was significant change in 2023. The CMS, which is the Center for Medicare and Medicaid Service, has remove the restriction of amyloid PET. Like previously, it was only limited to clinical trials, and it was only one PET-CT for the lifetime of the patient. But this has been removed in 2023, which is a very important development. This is followed after like this monoclonal amyloid therapy advancement. And similarly, there is no non-coverage policy for the tau PET as well, meaning it can be approved in certain circumstances, but still, currently we're not having this tau PET in our center. I think it's mainly limited to, hopefully we will see some changes in the future, but there is no coverage policy by the CMS for the tau PET as well. Okay, so what is the goals of this updated appropriate use criteria? The main goals are it helps to guide the clinicians on how to use the amyloid or tau PET, and it clarifies which one is appropriate, uncertain, or rarely appropriate clinical scenario. And this properties criteria integrates the PET biomarkers with evolving Alzheimer's disease therapy. And it supports a cost-effective and evidence-based use. And development and methodology. This updated properties criteria was prepared by the Alzheimer's Association and ESNMS multidisciplinary work group. Okay, this group was, I think, initially established in 2020 when I was reading the paper, introduction of the paper. They start working on this appropriate use criteria starting 2020. And like during the COVID pandemic, they were having like a teleconference meeting every 2 weeks. And I think they meet one time in 2023 in person. And for this appropriate use criteria, um, 14 members has been participated. Like of these 14 members, 12 of them are from United States and 2 are from Europe. And 5 of this 12 participants were nuclear medicine physicians. And for this review, they extract about 3,000 papers which are related to this particular topic, and they came out like in the final result, only 27 publication was reviewed for this review paper. And this review was done by the Oregon Health and Science University, and they use the modified Delphi appropriate, approach to write the 17 clinical scenarios. The ratings were like they group them into 3. If the grade is 1 to 3, it's rarely appropriate. If the grade is 1 to 6, it's uncertain, and grade 7 to 9 is appropriate. So just to have some like highlights about amyloid PET, I will come back to the paper. This is also mentioned in the paper. So this amyloid PET, of course, we are imaging. So it's very interesting to image the protein, which is the key protein in the pathophysiology of amyloid disease. So amyloid PET helps us to detect the amyloid plaque burden in vivo. This is a very good development. And in terms of its sensitivity and specificity, that like clinical data, available data showed it has um, the sensitivity up to 98% and a specificity of 95 up to 95%, which is very, very nice. Um, and we can use in terms of like for interpretation purpose, we can use, I'm going to discuss it in the coming slides, but for interpretation purpose, we can use the visual criteria, and we have some quantitative criteria like the ACUVR and Centiloid scale. So ACUVR is similar, it's similar like the ACV max that we use in assessment of other cancers in FDP-CT, whereas Centiloid is a different stuff. I will be giving you some highlights on Centiloid. So Centiloid centi means it's out of 100, and Lloyd is derived from amyloid. It's a scale of 0 to 100. There is a software to help you in calculating that. So we have a normal cutoff values, but the normal cutoff values are variable. But in general, like this was developed mainly for amyloid, not for the tau. So the general like there are kind of variable numbers, but generally you can be certainly sure that the scan is negative if the amyloid or the centiloid scale is less than 10. Anything between 10 and 30 is like equivocal, and this particular patient can quickly progress to amyloid stage, and anything above 30 is a positive. So unlike the ACVR, we have a cutoff values, and they use this centiloid criteria in the clinical trials, which results in the approval of these monoclonal antibody therapies for the treatment of uh, Alzheimer's disease. I think there is still like there are like this area is under research, but it's the gold standard for interpretation is still the visual criteria, but this one can help you as well as adjuvant, not as main means of interpretation. So having said this about amyloid, tau PET, it measures like the neurofibrillary tangles or the tau protein, and unlike amyloid, it's more closely correlated with cognitive impairment than amyloid PET here. And there are ongoing research on longitudinal clinical utility and quantitative standardization like the amyloid PET. So what are the appropriate scenarios for amyloid PETs? So those are the number one, the patient with mild cognitive impairment or dementia who is less than 65 years with suspected Alzheimer's disease. It gets the higher rates, right? Um, and patient with mild cognitive impairment or dementia above the age of 65, and atypical or mixed presentation, equivocal CSF biomarkers, and prognostic in mild cognitive impairment due to suspected Alzheimer's disease, and therapy eligibility for anti-amyloid drugs. This also rates high. And of course, monitor response to therapy. Those are the appropriate indications for amyloid PETs according to this updated appropriate use criteria in Alzheimer's disease imaging. And for tau PET, we have these appropriate scenarios. Similarly, patient with MCI and dementia less than 65, atypical clinical presentation, MCI prognosis, dementia prognosis, therapy eligibility. And the rarely appropriate ones, patients with CU stands for cognitive and impaired individuals or individual with subjective cognitive decline without risk factors. It's rarely appropriate. And tracking disease progression in established Alzheimer's disease, also rarely appropriate. For non-medical use, for insurance, legal, or employment purpose, it's inappropriate. Uncertain for someone with a cognitive and impaired individual or subjective clinical decline without risk factors. Tracing disease progression. Yeah, I think I'm repeating it. So yeah. The other topic is that they discuss in the paper is integration of this PET tracers with other biomarkers. Amyloid and tau PET complements the CSF and plasma biomarkers. Of course, the plasma biomarkers are not yet approved by FDA, but they're very much promising. And especially the plasma phosphorylated tau 2170 and amyloid beta 42/40 ratio shows high concordance with PET, and fluid biomarkers may detect pathology earlier than PET. Yeah, so the fluid biomarkers, the CSF biomarkers, they detect pathologies earlier than because they usually detect the soluble parts. And the CSF biomarkers of amyloid and tau, CSF amyloid, in some of the patients that they send us here, I see they have amyloid beta 42 CSF being done, but I think this is invasive procedure. I don't think the patients will like it, especially if the CSF and the PET finding is very the concordance. This is kind of invasive, but it can be positive in up to 40-60%. And amyloid beta 40 is not sensitive. There is high concordance between CSF, the ratio, amyloid beta 42 and 40, and with the tau ratios with amyloid PET scan. So the ratios outperform than a single measurement when it comes to CSF biomarkers. And the CSF tau, so the total tau is not specific for Alzheimer's disease because it can be increased due to stroke or traumatic brain injury, other neurodegenerative disorders. So phosphorylated tau 181 and phosphorylated tau 2117 has increased specificity than the total tau. And the phosphorylated tau correlates with amyloid and tau PET when compared to the total tau protein level. Plasma biomarkers is very promising, but I think they're not currently approved by the FDA. But the study shows that there is a like strong correlation with imaging findings. Maybe we'll see some changes in the future. Um, so the other topic that I want to discuss is amyloid PET value and superiority over fluid biomarkers. Okay, so the one is it provides spatial distribution of amyloid, not capture by CSF of plasma protein. The other point is enables quantitative tracking of treatment response, like using the Centiloid scale or SUVR. And it's less influenced by systemic factors like renal function, BMI, or other plasma proteins, and offers visual confirmation for indeterminate biomarker results. And standardized visual read and ACVR or Centiloid ratio ensures reproducibility. Okay. So that should be like integration between the biomarkers and the PET. So there is a tendency of detecting these abnormal proteins by the CSF plasma early, and PET visualize aggregated deposits like the insoluble ones, which are actually the target for the monoclonal antibodies. So it's complementary role like biomarkers for screening and PET for confirmation and staging, and of course for treatment response assessment. And the limitation is like the cost and the accessibility, of course, hopefully to not be same. We will see some change. Okay. Other limitation is that we need to know is a positive amyloid PET scan is not diagnostic of Alzheimer's disease. And amyloid can be present in cognitively normal individuals. Like it can be positive up to 10% in patients under the age of 70, even up to 40% in patients above the age of 80. So it is not specific. So the results must be interpreted in the clinical context with history examination and other biomarkers. This is for amyloid. So the suggested workflow according to this appropriate use criteria, the patient should be evaluated by dementia expert, then PET referral and acquisition, then expert interpretation and report, then integration into clinical diagnosis, disclosure to patient and caring parents. The clinical implication of this appropriate use criteria. Number one, guide prognosis, patient counseling and safety planning, and reduces unnecessary diagnostic procedures, and supports precision diagnosis and therapy eligibility. Like, so this therapy, the currently available therapeutic agents that I was saying is lecanemab and donanemab. There are both monoclonal antibodies. So as you can see in this picture, this is a amyloid cascade. If there is something in the amyloid precursor protein, if something happened, like for some reason, if there is misfolded, this cascade can be happen like we can have this um, insoluble and soluble fibrillars. So these monoclonal antibodies work at different stages of the amyloid. As you can see here, the donanemab, which was approved by the FDA in 2024, it mainly works in the insoluble plaques, like the amyloid plaques, whereas the lecanemab, which is also approved in January 2024, it's unlike the donanemab, it works in the soluble parts of the amyloid, like the protofibrils, right? So just to show you like how like so normally this monoclonal antibody therapies, they are indicated for a patient with mild cognitive impairment, meaning like those particular patients which are eligible for this monoclonal antibody therapy, they can make a decision by their own, like um, they have mild cognitive impairment or mild dementia, their performance is very good. So what the finding, especially in the lecanemab trial, what they found is there was a significant drop in the amyloid burden. They use a centiloid, the one that I was discussing. Centiloid scale, as you can see here, the y-axis is indicating the centiloid, the numbers, and the x-axis is the amount of the duration of treatment. So as you can see, there is this curve. There's a gap, huge gap between the placebo and treated groups. It's basically, I'm going to discuss this one in a later slide, just to show you an example. So a positive scan looks like that, and which means it's changed like this. I will be showing you some better images on the how do we interpret, how do we say positive or negative. But it's basically if the initial imaging was like this before the treatment, it becomes like this, right? And the other thing is it can decrease the amyloid plaque. At the same time, it can slow the clinical decline or the disease. It doesn't cure per se, but it decreases. We said Alzheimer's disease is a progressive neurodegenerative disease, right? It can delay the disease progression. So same thing. There was a if you can see the p-value is significant, and there is a significant difference between the lecanemab and placebo groups in terms of the clinical slowness, the clinical progression. I think with lecanemab, the progression rate was decreased by approximately near to 27%, and donanemab, it was about 35%. So now we will discuss about the interpretation criteria. This is a table that I took from the paper. So they present the currently available radio tracers. As you can see here in this table, these three amyloid beta tracers, and we have only one tau beta tracer, which are FDA approved. So on this table, if you can see on the right corner of the screen, they have actually indicate um, like when do we see a positive or negative? Like there is, look at this one. So we say scan is positive. Sorry, I'm going to show you like a practical examples on that. So if there are two or only one, if gray matter uptake exceeds white matter uptake, that's for amyloid. And it's the same for and we use different color scales for the different radio tracers, right? For tau, we have this um, like interpretation criteria, as you can see here. So I think you can go and read this interpretation criteria on the paper as well. So they also present these example images from the paper. So the color scales that we use in this different tracers should be different. Like for example, here at flu, we use this amyvid or phototopitapir. So it should be gray white color, and they showed us here negative positive. Like as you can see here, a negative scan, we usually see like we don't see this amyloid going to the cortex or the gray matter, right? It's mainly limited to the white matter. And as you can see, if it's only in the white matter, we call it a negative, like these pictures. If it is extending to the cortices or I mean, yeah, it's only white matter. If it's extending to the gray matter, it's a positive like this one. Okay. And this is an example of positive tau PATE, and this is for the other tracers. So we use different color scales. So for example, I'm focusing here on the tau or amyvid because it should be interpreted on the white and gray scale colors, right? So the gold standard for the interpretation is a visual criteria. We have this dichotomous results we give, either we say negative or positive scan. So if it's negative, tracer uptake confines the white matter, and gray-white contrast preserved, and this indicates absent or spare amyloid plaques. So I'll show you as an example. As you see, This one is an example of a negative scan. The amyloid is only limited to the white matter, so it's not extending to the gray matter. Um, um, like similarly in different like frontal temporal region. This is an example of negative. Actually, it looks like this one. Usually I don't know, I don't think that it's true in Egypt, but the trees during the winter, they look like this here. So it looks like, and Dr. Osman always tell us, it looks like our digit. Like if it's negative, it looks like a digit, or it looks like, this is from our SNA that I took. It looks like a tree in winter if it's a negative scan, right? So the activity is only confined to the white matter. You don't see extension to the gray matter. The positive scan, there's a loss of gray-white contrast, as you can see here, very dark, like the amyloid is extending to the cortices or to the gray matter. And it looks like a tree like this, like during summer, the trees are like here in San Luis. But I think it's very good representative. So it's a kind of smooth, it extends all surfaces, a good examples of a positive scan. And I said visual criteria is a gold standard, right? So normally reporting, we say positive or negative. These quantitative parameters can be helpful, but they're not, they're additive. The gold standard is still the visual criteria. So this is our reporting templates. Like for like, it's just showing this our template. If we have additional findings, we add them here. But this is basically our template. And we give them, for example, this is a template for positive scan, and we write some disclaimers about the scan here. And this is our template for a negative scan, right? Our disclaimer includes that here we tell them like a positive amyloid scan doesn't necessarily mean the patient has Alzheimer's disease. Like as I said it before, amyloid is not a very it's not sensitive. I mean specific. So we should use this amyloid PET scan. We should correlate it with other biochemical biomarkers and clinical examination findings. So we usually add this disclaimer in the as a footnote of our report. Okay. So I have some examples that I want to show you, real clinical cases. Okay, let's start from this case. This one was a 74-year-old female who presents for follow-up for cognitive impairment of 2 years duration. This is from the neurology notes that I was reading for the patient. The patient was started on Kisana is donanemab, the other name for this monoclonal antibody. She was started on the infusion on August in August 2024, and she came back to us in April 2025. I will be showing you the treatment also. So she was getting infusion every 4 weeks. She tolerates well with the treatment, and she had denied any neurological symptoms because sometimes we see some hemorrhage related to this monoclonal antibody therapies. So usually these patients are under close monitor with MRI. So this patient was doing well. And even like this patient has actually clinical improvement of like hair dementia. So basically, the purpose of this treatment monoclonal antibody therapy is to decrease the progression, but they said this patient had clinical improvement, and as well as I will show you the image. This was the initial image. As I was showing you, it's very positive, right? You see increased like activities throughout the brain, like extending, including the white gray matter, like frontal, temporal, uh, the entire brain, basically. So this was very interesting case. And I said, I think then this was like after 6 months of therapy, she came for follow-up, and basically it's negative. You see, there's a remarkable difference between these scans, and it was very impressive. And this, as I said, the initial PCT was in July, and this one was in April. So this was very impressive. And uh, yeah. The other case, which was done last week that I want to show you is this was an 86-year-old patient initially presented after being referred for memory problem by geriatric medicine. She complained noticing short memory difficulty since 2 years back after she experiences a failing incident that caused head injury with CT scan result of small supraparenchymal hemorrhage, but the repeat MRI was normal and her neurological examination was suggestive of neurocognitive disorder, and they were suspecting Alzheimer's disease, and they sent the patient for possible diagnosis. This is like indicate according to the properties criteria. It's appropriate to do amyloid PET scan for this patient. Okay, because initially they did MRI. As you can see, the MRI was read as a negative, and it was there was nothing. There was no any residual hemorrhage or any structural abnormality which tells or which speaks for the patient's neurocognitive decline. So they sent the patient for uh, PET, but it was negative, right? As you see, it was negative. So they should. Um, there are other neurodegenerative disorders which are not typical, like outside of Alzheimer's, which could result in dementia, I think. But this is just the purpose of this case was to show you other negative scan. Okay. Other case, a 68-year-old gentleman. This was from Friday, actually, from the study, which was read by the classman. This one was 68-year-old gentleman referred for memory concern, accompanied with his wife. This patient has like he didn't like he is not even having any know-how about his memory problem. He say I don't have any memory issue. That his wife was telling the clinician. I was reading this from neurology note, and wife reports memory issues ongoing for more than 2 years. Even he couldn't, like his sister was passed away recently and he didn't remember about that. And he believes his father is still alive, but that's not true. He has difficulty of using things like how to use the phone, does things repeatedly like checking the doors. This is very devastating for the family. But yes, according to the appropriate use criteria, this is appropriate to do amyloid PET scan. And it looks like this, right? Yeah, so it's very positive. Like there is, as you can see, um, this image shows you the frontal and occipital parietal region. There is amyloid deposition throughout white and gray matter and throughout the brain parenchyma, actually, these temporal lobes, frontal, occipital, parietal region. So it was positive for as for amyloid. So like looking at his clinical presentation and the amyloid PET imaging finding, we can say with confidence, I think with this patient, he's likely having Alzheimer's disease. He could probably, I don't know if he can be the best patient for this monoclonal antibody therapy because this monoclonal antibody therapy mainly works, as I said it previously, it works best for mild cognitive impairment, or I think stage one. Maybe he could be a good candidate. We will probably see him coming for treatment response assessment. Okay, so the last point will be what are the further research questions? This is discussed in the paper as well for amyloid and tau PET. So optimizing therapeutic guidance. So currently, this monoclonal antibody therapies, um, so the duration of therapy, I think in the clinical trials, they give this treatment for 18 months, right? Um, so they follow them with MRI, periodic MRI, because there is a tendency of bleeding hemorrhage or as a result of this monoclonal antibody therapies. They follow them periodically with the MRI. But I think there's a tendency like we can we like shorten the duration of treatment based on their response to the treatment, like by doing amyloid PET scan, like the patient that I showed in the prior example. So that's the future like it can be yeah, that's what I say. And it can be used for longitudinal PET changes and can guide treatment duration. Yeah, duration for duration stuff. Yeah. And like optimize the quantitative versus visual interpretation criteria. They're still undergoing, like the centiloid scaling is very important objective criteria, especially for treatment response assessment. But I think a study needs to be done how these quantitative parameters are uh, like agree each other comparing with the visual interpretation criteria. And there needs to be study needs to be done on that particular topic. Um, and explore the combined visual. I think I'm out of time. Then the other point that needs to be discussed is currently there is only one tau-based tracer, and this tau-based tracer is its sensitivity is limited, especially during early tau pathology. It can only detect the advanced stage. So there are currently new tracers under investigation, which are for tau imaging, and we should evaluate these tracers as a future research and explore any alternative visual read for early Bragg stage, because the tau plate Bragg, there is Bragg stage zero where we have stage 1, 2, 3, 1, 2, 3, 4, 5, 6. So basically Bragg stage 5, 6 is when you see um, the deposition of this tau protein in the neocortical region. So basically we detect the Bragg stage based on histopathology, but based on imaging, we detect the advanced disease like stage 5, 6. So a study needs to be done if we can detect this tau protein, which is very important protein and which has directly correlation with disease severity. If we can develop any visual rates that could detect, this needs to be studied. And of course, semi-quantification may enhance diagnostic values. And we need new tracers, other proteinopathies like, of course, there are alpha-synuclein and TDPA. There are clinical and animal studies on alpha-synuclein and TDP43, and we need to do more studies on that, like beyond the proteinopathies for Alzheimer's disease. So in summary, the updated appropriate use criteria is clear, evidence-based, guidance, and we have 7 appropriate use criteria defined for amyloid and 5 for tau PET scenarios. Um, Amyloid PET confirms Alzheimer's disease pathology and for treatment eligibility, of course. Tau PET correlates strongly with disease severity, unlike the amyloid PET. So we need to integrate this PET with emerging fluid biomarkers, which represents the features of Alzheimer's disease care. And this supports a personalized, cost-effective dementia management. Okay, that is end of my presentation, and thank you very much.
Thank you very much, Dr. Keflo. Very nice presentation, very comprehensive, very insightful. And to start with, I have 2 questions before giving the floor the chance to discuss with you. Firstly, what is the value of actually special resolution, special distribution, or spatial biodistribution of amyloid by BET? And this is a systemic disease. Again, it could be solved by the CSF biomarkers. What is the add value of doing BET to localize a spatial resolution or spatial biodistribution of a defect in a systemic disease?
Yeah, that's a very wonderful question. Actually, this is like Dr. Eisman's. Dr. Eisman is very interested to do this research as well. Yeah, so w- like we know cardiac amyloidosis, there is a petrol, especially for the light chain type. Like if there is systemic amyloidosis, of course, we can detect it with amyloid PET scan, but I don't have any special experience with um, like systemic amyloid PET scan for systemic disease. It will be very interesting to see um, how this amyloid can be like, I don't know if there is a tendency to, it's very, very, very nice question. And um, I don't know how this patient's whole body amyloid PET scan will look like if we did this amyloid PET scan, especially for those patients who has a positive amyloid PET. That I don't have any specific experience with that, but and we do for especially for ATTR and for the cardiac amyloidosis we do the the bone scan, actually the PYP. The other systemic amyloidosis, oh, I don't see like doing it frequently, but it's very interesting topic. But I don't know if I get if I'm answering your question. But in terms of like the added value of this amyloid PET scan, comparing to the safe, number one, I think I touched it in my presentation as well. So the clinical trials which results in the approval of these monoclonal antibody therapies, they use PET, both especially for the donanemab, they use PET and tau and amyloid PET as inclusion criteria. Like if the patient um, and we can assess visually the amount of amyloid deposit in the brain, um, unlike the CSF. And in addition to that, I think about 25% of patients who have a positive um, evidence of amyloid on CSF, they may not have or they may not be eligible for um,
Immunotherapy.
therapy. So it's very essential to have this imaging modality before proceeding. There are like important component of this selection criteria. So you need to have um, amyloid PET before receiving this monoclonal antibody therapy.
Mm. Could we consider the negative bit as a good negative bit, or could we consider it a bit amyloid uh, um, uh, has a very good predictive negative predictive value?
Yeah. So with the CSF, the sensitivity specificity is above 95%. It's very specific. I mean, in terms of like its correlation with the CSF. As we said, a positive amyloid doesn't mean you have. Unfortunately, we can see it in a normal individuals as well. Especially amyloid is not directly correlate with the disease severity. That's
Mm.
why we need to correlate with whatever clinical finding and biomarkers. Um, uh, Having a positive amyloid doesn't mean that you have Alzheimer's disease, because we can see that in up to 10% of patients below the age of 70, and even up to 40% in the patients above the age of 80. So we need amyloid is not amyloid positive doesn't mean that you have Alzheimer's disease. So you need to integrate the clinical finding and the biomarkers.
Okay. Professor عبد الحميد الجزار. Good evening, sir. Uh,
Good
are you with us?
evening.
Would you please, sir, join me for firstly for thanking Keflom, and then give any idea, brief ideas about the pathophysiology of Alzheimer disease from your experience?
Yes, actually, thank you for the nice coverage, and at the same time, he actually covers this that there is extracellular amyloid plaques that are the hallmark of Alzheimer disease, and also he covered the tau deposits, which are proteins necessary for microtubule stability in neuronal axons. But the excessive phosphorylation of the tau leads to its aggregation forming neurofibrillary tangles, which are behind the neuronal damage in Alzheimer's disease. And visualizing or detecting these tangles alongside the amyloid plaques in Alzheimer's disease is useful, as was mentioned, to plan treatment and also to evaluate the clinical severity of the disease. One more thing I like to add, which is not related to Alzheimer's disease, is these amyloid binding tracers were found unexpectedly to bind to the myelin and is being investigated in evaluating multiple sclerosis. So this is, we are waiting to see its value also, like the tau PET tracers in multiple sclerosis. Thank you.
Thank you very much.
Thank you, sir. Thank you,
You're
sir.
welcome. Thank you.
حسين دكتور حسين
السلام عليكم.
عليكم
Thank you,
السلام.
Dr. Kaflon, for your presentation. I have two questions. Are you in St. Louis use in clinical practice amyloid PET for monitoring treatment response as a routine?
Yeah, so yeah, that like the example of the patient that I showed you, that we're getting patients. So the thing is, this monoclonal therapy there's a long-term therapy, and these drugs are recently approved, like 2024 last year. At least we saw, I think I personally saw 2 patients. So we're getting patients, and
we had 3 patients Kaflum over the last year, where we saw a therapy, assessing responsive therapy as the indication, because all of those 3 patients had a positive scan in the past. And I know for a fact that 2 of them, one you showed the images, showed response. I just don't remember if the 3rd patient was evidence of failure of response or successful response. But the big thing which you alluded to, Kaflum, is that there's an argument to make. If you show objective evidence of the removal of the amyloid, so scan was positive and after therapy turned negative, why, if I'm a patient, continue for life taking an expensive and an immune therapy which has significant side effects? And insurance are interested in that because they would rather the ordering physician saying patient responded, memory is better, subjectively as well as objectively, there is no evidence of amyloid deposit, the scan turned from positive to negative, I'm gonna stop. This is similar to the argument that we make in the prostate cancer world, for example. Doses of lutetium and the PSA is undetectable, do you just continue the course just, or do you say, okay, well, I'll save this for a later time, there's no reason to give the treatment since there is no evidence of tumor and the PSA is undetectable? So I think it's not this criteria, but in practice, Hussein, the ordering physicians are now. And I think, like anything else, and Kaflum alluded to this criteria is not meant to be forever. And they started developing this in 2020, and with some delays because of COVID, and it was finalized in 2024 and published in 2025. The coverage started in 2023. So this is relatively new we went from doing more brain FDG to certainly more amyloid, and doing one amyloid every blue moon to now doing this at least 2 or 3 of these per week. So in fact, Friday, as Kafloum said, we read 2 cases on Friday. So that was not the case a year ago. So we're seeing more indication of this. And I think it's an opportunity for Egypt, whether it's the military or the academic settings, for someone to start, because as we are living longer, and I don't trust, I know Kafloum presented data, but being from Egypt, I can tell you that it is probably underreported because of the stigma related to that. But the truth of the matter is, as we age and we live longer, the diseases like cancer and cardiac and dementia issues, we're going to see more and more of these patients. So I think it's would love to see this being part of the different tracers and different imaging modalities that are offered in Egypt, inshallah.
Thank you, Dr. Medhat. I am taking from your word another question. What is the position of FDG PET-CT in the era of amyloid PET? Are you still using?
You have to come back to St. Louis and spend a year with us to get the answer to the questions. I think it's actually the same supplement that Kafloum was making reference to. The following article to the one that he shared with us today has FDG, and there's we recently had a problem actually at SLU. A neurologist sent me an email complaining that he ordered FDG PET and the scheduler at the hospital canceled it and changed it to Amyloid, to amyloid scan, and he wasn't happy, and I wasn't happy. And we certainly, I apologized and I said that's the scheduler's problem. There is still a room to do FDG, but the indication is different, meaning these are typically earlier memory problem issues, but the dementia, Alzheimer type, has not been the diagnosis yet. The FDG plays a role in, there's one good thing and one bad thing about the FDG. It's typically someone with more advanced dementia, and you want to decipher who is Alzheimer related versus frontotemporal versus Lewy body, other causes of dementia. That's the role that the FDG does. The problem with the FDG, and that's why even though FDG brain has been around for a long, long time, in fact, FDG brain was way before FDG cancer imaging was ever introduced in the world. There's no treatment for it at this phase. The unique thing about the amyloid now is that there is treatment and there is objective evidence and subjective evidence that it works. The FDG indication in the brain now is to differentiate different types of dementia from each other.
Yeah, thank you, Dr. Clear.
Thank you, Dr. Medhat. Dr. Tariq Maghrabi. Tariq Maghrab.
Yes, hello, Dr. Khaled. How are you? Thank you so much for giving me the.
Welcome, sir.
Thank you. Thank you, Dr. Kafloum, for the very nice, informative presentation. And I think I'm very glad to hear about that. And thanks, Dr. Medhat, for also the very nice comments you gave. I just have a quick question from your experience. I was very astonished by the quality of the images and how positive is positive and negative is negative. And finally, in nuclear medicine, we see something very sharp and binary. But at the same time, also, we are stuck with this kind of, if you have a positive scan, that doesn't mean that you have an Alzheimer, which is understandable. And of course, you need the clinical data and all these things. So, and I also see in your report a disclaimer, which is even more in size than the report itself. So is there a way that you can supplement your report by something like a note from the physician or a survey you do for the patient before doing the scan, that at the end your report becomes really conclusive rather than saying it's positive, but this is my disclaimer. So I'm, as a nuclear medicine, stepping back and leave it all for you. So yeah, sorry, the question is long, but I'm just trying to get my worry to you.
Yeah, I'll take a shot at answering Dr. Tariq. So number one, it's a medical legal issue. These tracers are approved for a specific indication, and the language used at the bottom of the report is dictated by all the three FDA-approved amyloid imaging agent, that there is one form or another, and in that case, it's an Amyloid, where it's cut and paste from their FDA approval. That's one. Two, the reality of it, it's not a one-to-one ratio that if they have amyloid deposit, it is related to Alzheimer, as Gafloon covered in his presentation. So it's evidence of amyloid deposit. That's it. It's a predictor that there's higher chance of this patient at one point in time developing dementia, but when it could be 10 years from the scan being positive, and then the other way around, someone can have a positive scan but not having dementia. So that's why we cannot say this is consistent with. That's up to the clinician. We are giving them the answer to the simple question: does the PET scan show evidence of amyloid deposit? Then they incorporate that in the decision-making process, whether to start the patient on the treatment or not, based on additional pieces of the puzzle that they do extensive. That's why part of the limitation of the scan is it cannot be ordered by internal medicine physician. If you read these appropriate use criteria, part of it should be ordered by what is called dementia specialist. So, which there is a definition of who would qualify for that to order the scan. So it's not being over or underutilized. But from the imaging point of view, some of these studies should be read without being biased by the clinical history. And that's why it's a binary read. And it's a simple, do we have evidence of amyloid deposit or not? And I tell you, I'll take advantage of the fact that I can see we have a couple of other people from the team attending. One is Mehdi, who's our first-year resident. And then the other one, we have a physician who graduated from Bosnia, Lamia. And these scans, it's technically, if you stick to a protocol and you have a decent camera and you avoid patient motion and all of that, it's easy to read. So I'll turn around yet actually on Friday, not to put Lemmy on the spot, which she's not a nuke med physician, at least not yet. And I'll say, what do you think? It's positive or negative? And she can say positive or negative based on looking at scans over the last 2 or 3 months. So it's not like most of the other studies where it's more complicated to read it. Now, most of the time, and 99% of the time, we can say this is positive or negative. But I'm aware also of, in the US, of the insurance. If you put in the report something, then A, you cannot take it back, and B, it may forever affect that patient's insurance. So if there is uncertainties, if it is not clear, then we will articulate that in the report. But so far, we're able to keep the binary read positive, negative, but we're going to add to it as of November 1st, having a MIM software so we can add quantification. So at least that's another layer. Plus also, if you treat, not every time you're going to treat, you're going to see definitely positive to definitely negative. What if it is positive but not as positive? That's where quantification can play a role to tell the physician it's getting better, but continue giving the treatment, versus the example that Kaflum gave you, it's definitely negative, you can stop the treatment now.
Yeah, thank you. I think that was also my second question about whether the binary thing will also apply when you are following the therapy, or you can also say, well, the patient is improving, but not yet to the point of being negative. So that was another question, but you already answered. Thank you so much for that.
Yeah, I think if I have to guess, the neurologists, they know the patient's symptomatology is getting better, right? I mean, they can tell the patient is getting better, they're feeling better, the family are reporting, they're noticing a positive change, but they want from us objective evidence that there is no longer positivity in the scan, therefore they can stop the medication and whatever the cost and side effects associated with the medication.
Right. Thank you, Dr.
Thank you.
Osman.
Thank you.
So,
Thank
yeah.
you very much. Dr. Mahdi Zidan. Dr. Mahdi Zidan.
Hello. Yeah, thank you for having me.
Would you please introduce yourself firstly?
Yes, my name is Mahdi. I'm as Dr. Osman mentioned, I'm the first year resident in nuclear medicine at St. Louis University Hospital. Thanks for having me, and thanks for Keflon for the great talk. I just wanted to point some stuff. First of all, the quantitative PET amyloid imaging are not fully FDA approved. As far as I know, they are partially approved, but I think the MIM software is going to get approval very soon for some of the amyloid imaging analysis. Second, actually the SUV that we use for the quantitative analysis is the SUVR, which is a ratio. So we use the ROI in that specific region, for example, parietal or like a temporal to the cerebellum, because cerebellum is not heavily affected by the amyloid imaging, by the amyloid plaques. And the third point is that I think regarding one of the questions, the type of plaques that we see in amyloid in the Alzheimer's disease is very different from amyloidosis, like a systemic amyloidosis. That's actually the reason that we use actually different type of radio tracer for systemic amyloidosis in comparison to Alzheimer's disease. So those are the points that I just wanted to mention.
Mahdi, I'm glad you made this comment because I forgot to talk about it. When we were doing cardiac, and we're still doing cardiac amyloid, but at least the first few patients, I was doing whole body imaging to see when we have positivity in the heart, would we see it in other parts of the body? I didn't see any, but I know a colleague of mine who give a talk about it and show some evidence of amyloid deposits in other parts of the body when the indication is cardiac. But to the best of my knowledge, it's amyloid, but it's not at some level, it's not the same amyloid that we have in the brain. But I still think it's a valid point that made by Dr. Khalid. Well, we have nothing to lose. And I will let you guys know when we have a positive scan, I'm just going to have to figure out a way how we can incorporate that when you have 10 to 12 PET to do, because when they schedule the patient, the brain takes less time. So there is another patient injected with another tracer that's ready to go. How to image the rest of the body, but I'll have to figure out a way to do it. Maybe change the scheduling to make the brain PET amyloid as the last case in the day, so we can do it to see if we see something else somewhere else. But from the cardiac amyloid, we did imaging of the whole body, and I didn't see evidence of amyloid deposit. But I know someone who showed me examples of seeing it in other parts of the body as well. Although that I don't think that was ever validated in a larger prospective trial.
Thanks, Dr. Medhat. Dr. Muhammad Abdel Razak, Professor Muhammad Abdel Razak.
Good night, Dr. Khalid, Dr. Walid, Professor Medhat. Thank you, Dr. Jibra Slassi, for this very wonderful and concise or highly demonstrative presentation. And also, I am admiring your presented cases. It showed really the evidence of molecular nuclear medicine in dementia and in Alzheimer in particular, with the follow-up with the new advent of the immunogenic drugs. Actually, I have one comment, as I think Dr. Mahdi referred to, regarding the specificity for amyloid in the brain. I mean, as a structure, as Dr. Abdul Hamid demonstrated, the phosphorylation pathology. And this is different than systemic, of course. Another thing is the question to Dr. Gibras Lassi about the quantification. The quantification here, the Centroid score, the reference area is the cerebellum, right? The whole cerebellum.
Yeah.
Some articles did the inferior cerebellum, not the whole cerebellum. What do you think about that? This is number one. Number two, the different amyloid image or tracers, right? Like, for example, Visamil. Of course, we have the reference as in visual interpretation, which is the bones by criteria. How can we match this with the quantification? I mean, centroid index regarding the cerebellum would be the reference region.
Yeah, that's very nice. Thank you for your comments, and this is a very nice question. We don't have very great experience. Personally, I don't have great experience, like besides reading from like what I read is hopefully we will have this software, because we have currently FDA approved available softwares, and MIMI is one of them. I think amyloid is not frequently like cerebellum is the least affected organ, like site. So what I read is we use the cerebellum as a reference point, and the whole point is, I think, this quantitative parameters, the Amyloid scaling, there are research undergoing currently. I'm not so sure about which particular area is better and what like to answer your question, but what I know or understand is still the visual criteria is a gold standard, and it's very great to have these quantitative parameters, and the cerebellum is the reference point, and the quantitative parameter has its own drawbacks, like it can give you a wrong number, like wherever you put your target area and reference point. Let's say, for example, if the most affected area is in the frontal lobe and your target area, if you put the target area somewhere in the temporal region, you might have a false negative results with these quantitative results, quantitative parameters. Yes, in the clinical trials, which results in approval of this monoclonal antibody therapies, they use Amyloid scaling as a treatment response assessment. And the future plan is to have more consolidated knowledge about these quantitative parameters. And it's really like how it relates with the visual criteria. But unfortunately, I don't have a very good answer for your question. Yeah, well, yeah, we can go and check that. I think I'll double check on your question. Yeah.
I think I would say about the quantification that this is what would be labeled as work in progress, meaning it's not standardized. Different softwares out there with different reference point and different way to do the quantification. But that's precisely why right now, from the FDA approval and payment by insurance, and the utilization and approval of using medications that are very expensive and potentially toxic is all based on visual. We will add to the quantification when we have the MIM, because they have MIM Neuro as a separate section. And as you can tell, Mahdi, even though he's our first year resident, but he has extensive experience with using MIM. So we will be working on this from the research aspect of things to see what's the discordance between our visual interpretation. Does it really matter? Can the quantification add anything? For now, it doesn't change the read. It may be more sensitive, but ultimately it doesn't change the read of the reports. So it's not standardized. So it's not part of the standard of care of anyone that I know of in reporting the amyloid scan report.
Okay, Prof. Madhat, thank you very much for this clarification. I have also a question regarding, or just what is put by Dr. Jibra Slasi regarding the FMK 6240, which is under research now, I guess. But as you know, it is validated in comparative or what's called head-to-head comparative studies. But actually, it's not correlated with post-mortem pathology, like fluor-tau-CBR, which is approved by FDA, which is the only one actually approved because it is correlated with pathology. Do you think that this new agent will be promising because it is not validated with PM histopathology?
I think so. Yeah.
Well, I mean, it depends whether whoever, it's all about the industry, who's putting their weight and funding to validate something. But the fact of the matter is, even though tau has been around and FDA approved for a long time, this is something I don't know whether you guys are familiar with it, that in the US, you have something that the company will sponsor something, you do a trial, then before they do the trial, they have to get approval from the FDA about the design of the trial. Then when they have the results, they present the results to the FDA, hoping for the FDA approval. Then when the FDA approves it, then legally you can do it, but you're not going to get paid till it's CMS covered. And you can have sometimes a gap of 6 months, or you can have a gap of 15 years between FDA approval and CMS cover. So even though the tau has been approved for a long time, as Kafloum said, it's a problem because who's going to pay for it? And even though, by the way, if you show tau positivity, that is also an acceptable route to get the immune therapy. So it does not have to be just the amyloid scan. If you have a positivity in the tau, you can make a case and patient can get treatment. But the insurance will pay for the treatment, but would not pay for the scan. Versus if you do amyloid, they will pay for the scan and they will pay for the treatment. So that's why the tau has nowhere to go at this point. So let alone if you have an alternative to it, it will have to show that it has higher impact than the amyloid scan, which is very difficult. This is similar to having lutetium PSMA made by Novartis, but then there is another lutetium PSMA made by others. How are they going to show that their lutetium is better than the lutetium that was made by Novartis? It's very difficult.
I guess, Dr. Medhat, it is hiding like the weaver because of, as you said, it's difficult to be detected. But I guess it depends upon CSF, the markers. I guess there are new ones like beta 25-1 and etc. Others. Those, I guess, investigations now, they might validate the tau imaging.
I think if there's any future for the stuff, at least based on reading this supplement, is the CSF problem is invasive. And that's why even though the CSF route versus PET imaging route, both are acceptable to select patient for treatment, 100% of the patient would select the PET scan. Nobody wants the invasiveness of the CSF, but the research is actually now in the plasma. So that if that works, then the good news, it may make patients say, I'll do the blood sample, and that is less and faster if proven to be accurate in the prediction of the presence of amyloid. So that's probably the most promising thing over the next few years.
Well said. Thank you very much. Thank you.
Thank you, Dr. Medhat. Thank you, Dr. Muhammad.
Thank you. And Dr.
I think-
Jebras Lassi also, I am very, I mean, I give you greeting. Thank you.
Thank you,
Thank you.
Abdullah. And I think, like, thank you, Dr. Osman, on the
Sure.
tau tracers. Like, I'm trying to remember this one, the new tau-based tracers. I understand the problem with the tau superior or the F18-based tau tracer, only tau tracer. It's not very sensitive for early tau pathology, like, and it is good to investigate for new possible tau tracers like the one that you mentioned that I'm displaying on my screen. And there's a hope that evaluating these new tracers and assessing the interpretation criteria as a visual criteria for tau imaging. Because with the current for tau superior, we can only detect the BRAC staging. If it's this histopath like BRAC, we can only detect the advanced stage 5, 6 and we're not sensitive,
Correct, yeah.
not sensitive
Great.
for the early pathology. And hopefully these new tracers, which are currently under investigation, they might be better than the only tau-based tracer currently available in the market. I think that's my understanding. And thank you very much for being involved. Very detailed.
Thank you very much.
Always welcome. Dr. Medhat, I wanted to know the price of the amyloid bit in relation or in comparison to FDG bit.
Well, FDG PET is definitely cheaper, right? There's nothing cheaper than FDG now.
No, what is the relation? Double, triple?
But Kafloom, do you know? I don't know, but I mean, like any of these tracers now is $3,000-$4,000.
حضرتك
but the
هتزعل
FDG
الدكتور عباس علافي يا دكتور مدحت كده.
نعم يا فندم. نعم يا فندم.
حضرتك هتزعل الدكتور عباس علاوي.
Well, but it's everyone is happy about how cheap FDG, and the problem is the other tracers, once they go out of the first 3 years, then they get a little bit cheaper. But for the problem is, like we went through this with the gallium PSMA versus F18 PSMA. As time goes by, they go a little bit cheaper. But the problem is if someone controlling the market, then they can maintain higher price. But I still think someone from Egypt needs to look into getting one of those 3 FDA-approved tracers, and I predict that there's going to be a big market to if someone will say I can do amyloid imaging in Egypt now.
We will ask about that. We will ask about. Actually, Dr. Medhat, the disease is not symmetrical. It is bilateral, but not symmetrical. Actually, have you experienced the asymmetrical Alzheimer's disease? Asymmetrical.
Well, are you saying amyloid deposit, or are you saying
amyloid?
Well, yes. I mean, it does not have to be following a extensive throughout. It does not have to be bilateral. But is as the example of the trees that he gave, if you have the frontal, or I mean, this is everywhere. You see what Kafloum said, the spring or summer trees. But if we read positive cases based on bilateral frontal, or one more than the other, or parietal or temporoparietal, So any one region, if you go to the table, Kafloon, that has the description of what constitute positive, 1 is enough. So if you look on the right side here, number of regions for a positive scan, this one is saying 2 or only 1 gray matter uptake exceeds white matter uptake, and then the other 2 tracers 1 and 1. So 1 area is enough for positivity.
Mhm. I ask this question for the continuity of medication.
Oh, well, I mean, we didn't see a lot of one area. I mean, most of the time when it's positive, it's multiple areas. And we're lucky that the example that Kafloon showed, like this one here, it's very clear. This is
Yeah.
diffusely positive. 10 out of 10 people would say it's positive. And the other one is diffusely negative. 10 out of 10 would say it's negative. So it's, but that's where we're talking about the quantification may play a role. As we see more of these cases, not all cases are going to be straightforward, slam dunk positive, slam dunk negative. That's where quantification may play a role, but we'll see.
Okay, thank you very much. Thank you for joining us, for giving us this long time. Dr. Walid Omar, are you still with us?
Yes,
Dr. Walid?
Khalid.
Could you join
They
me
were
in thanking Dr. Medhat and thanking Dr. Kiflo and thanking
Yeah.
all of the audience with us? Please do that for me.
Thank you very much, Dr. Kaflon. Your presentation was really great because this topic is new for us. The amyloid and tau imaging is new for us, so we learned a lot. For Dr. Osman, thank you very much for moderating also with Dr. Khalid this session. However, I wanted to ask a question, but Khalid didn't give me the chance. But as long as I got to say something, I would love to ask you how happy the neurologist with our reports, because this will give this feedback. If they are happy with the report and it goes with the clinical, I think there will be a future for amyloid and tau imaging. But if they are not happy with the response, because the clinical does not match the imaging, then it might be difficult in sending more patients to us.
Well, and that's why in that properties criteria manuscript, they're talking about who should order the scan. And if it's a dementia expert, then indeed what we are sending them, it's we're confirming, adding to what they're already suspecting. And I always tell our colleague residents that the number one in the impression should be addressing the question for which the scan is ordered. So in this case, their question is simple. Does the images show evidence of amyloid deposit? And if the impression is saying, yes, we see evidence of moderate to high amyloid deposit, then we answer the question. If the question is, patient is doing better, is the scan positive or is the scan negative now? Then we say there is no evidence of amyloid deposit. Then so far, the neurologists are happy with our study, how it is being acquired, and the image quality, because they have access to images as well, and they're happy of the report, and they understand why we put this disclaimer paragraph at the bottom, because they know
you
that.
Want to be sued, of course, yeah.
But it is also, keep in mind, patients are reading it. This is a big difference. In Egypt, you have to figure out how to get a copy of the report. Here, as a patient, the same day that I see my physician, I log in, I see my report. So you have to say, if you make a mistake in the report, you will hear about it from the patient before you'll hear about it from the ordering physician. Okay. So that's why disclaimer is important, because we tell patients, yes, you have amyloid deposit, but doesn't mean that you have Alzheimer, because you don't want to tell something in the report that is contradictory to what the ordering physician is telling them.
Yes. Yes, that's
I
very clear.
like
Very
to-
clear. That's very clear. Thank you very much, Dr. Medhat. And
You're very
we
welcome.
hope
It's a pleasure.
to see you with us more, you and with your residents and your colleagues in our Society Journal Club. It's very informative and very, everybody is happy with it.
I'm going to throw this at Mahdi since he is with us. Maybe next time he'll pick a topic to present on.
That's great. Thank you very much.
All right.
Thank you, Dr.
very
Kef.
good. Thank
Thanks,
you.
my pleasure.
And thank you for the
guys.
time you give us.
Thanks, Kifloon. Thanks. Bye-bye.
Thanks for all, and good night.
Good night.
For them in the morning, have a good
شكرا
day.
على
It's a
كده.
weekend. Have a nice
Yes.
weekend.
You too. Thanks.
Thank you.
تصبحوا على خير جميعا.
Thank you.
انت من اهل وخلود. مع الف سلامه.
مع السلامة.